All right, thank you all for coming this afternoon. We're going to get going right now. I'm Matt with Snowasis. Nice to see all of you again. There's some white cards out there on the chairs. If you fill those cards out, we're going to be giving some BioXclude away. There's a raffle box in the back, so if you want some free BioXclude, definitely fill that out. Very excited to have all of you here this afternoon. Excited about the panel we've got. Next up, Dr. Curry Leavitt's going to be leading our second session. And then hopefully we've got Dr. Fien, Dr. Brad Ross, Dr. Israel Puterman, and Dr. John Kim. We're going to hopefully give him a hard time as he's going through his cases. So, all right, I'll turn it over to you.
Thank you, Matt. Appreciate everybody coming out. Thank you, Matt and John, for kind of leading things off. And one of the things that I want to do with this is really talk about the versatility of what this membrane can do. So we're going to have a lot of fun with it. I'm going to try to utilize maybe the panel a little bit more than the other guys did. I mean, they're up here. Obviously, they look good, kind of, but we'd rather hear them talk and kind of give us some fillers in terms of what they think. Leading that off, I am from Las Vegas, private practice, periodontist. Started a private practice from scratch, literally in residency, 15 years ago or so. So this is the Las Vegas Strip. Anybody not been to Las Vegas? Who's like that guy? Like you're that guy? We're gonna go back together. We're gonna have a great time. Flying out Saturday. Saturday night will be great. Most of you have been to Las Vegas. You've experienced it. You've probably seen the Strip in terms of what it is. What makes one hotel better than the other? What makes the MGM better than, like, let's say the Cosmo, or let's say the Cosmo next to the Aria? Guys, you guys have all been to Vegas. I've done Vegas with Brad. I've done Vegas with Israel. Matt, we've kind of done Vegas. We've taught together. John, we've done Vegas together. All these guys have come to Vegas for a couple of reasons. Brad's like this big party guy. He likes to go to the clubs. So obviously, like, the Cosmo has this new club that pops up. So of course Brad goes, oh, we're going there. You're going to be in Vegas, in December, to opening up some other, what are you there for?
Just to say hello to you.
Yeah, no, that's not true at all. There's a new club that's opening up, so of course Miami Brad goes out. He wants to be a part of that. And then Matt's like a big foodie. Every time we go to dinner, he orders everything on the menu, wants to try everything. So let's say Bobby Flay opens up something at Caesar's Palace, and he goes, oh man, this brand new place is opening up, brand new restaurant, let's go there. So that's appealing to him. Israel comes into Vegas. He typically is 3 blocks off the Strip in the sketchy stuff. Yeah. So we're going to leave Israel out of that. Israel comes and goes to hockey games with me. We're big hockey guys, and so he'll fly in for 24 hours and go to a hockey game. And then John, I'm not going to talk about John because his is way out there. So super, super kinky stuff. So, but anyway, with that, what really makes these places different, okay? And so what I want to do, and I think there's kind of a precursor to kind of where we're headed with all this, is that what are you going to do in your practice, let's say on Monday, that's going to make you different? That's why you're at a conference, right? That's why you're here. You're here to hang out with colleagues. You're here to hang out with, some of your friends, maybe people you went to residency with. But really, when it comes down to it, where's those kind of little things that I'm going to bring back to my practice, whether it be practice management, whether it be materials, whether it be, technique, colleagues that maybe I can lean on. And so as we go through this, kind of keep that in the back of your mind, going, what is going to make me different, okay? What's going to make it different, like what the Cosmo maybe is doing for Brad or the Aria is doing for John? So we're going to talk a lot about, we talked about the smiley face, this cute little smiley face. It's a barrier and a carrier in one product. There's a number of reasons why we like that, okay? Utilizing growth factors and a number of parameters in terms of what we do. We talked about it already, so we're going to go through this really quick. But immunoprivileged, antibacterial, anti-inflammatory, accelerated healing. We add that to our surgical sites. Really, we kind of ramp things up pretty extensively, okay? And so with that, there's over 200 growth factors in the BioXclude membrane. With this, we get cell proliferation and tissue generation that's exceeded with any other products that I've used in the past. And so with that, I'm not going to go into literally a month's worth of work to try to explain any of this. I don't know any of it, but it doesn't matter because they're there, okay? So we're going to reinvent the membrane rules. We're going to try to keep things minimally invasive. We saw a bunch of socket grafting. We see we don't need to trim things, with GTR procedures. No need to fixate these membranes. They drape over things really, really well. And we got this unmatched adhesion. So we're going to talk a lot about ways that I've used this in my practice to really benefit, really ultimately who's benefiting from this. Me, it's because it's easier, but it's also for the patient too. And so I was a big David Letterman fan growing up. I was one of those kids, even like when I was like 10 years old, I would stay up late. And just to watch the top 10, the David Letterman top 10. You guys remember that? And so we're going to talk about the BioXclude top 10 ways that I use this membrane. Okay, a number of membrane uses, and very successful. So our first case, you can obviously see where our defected area is. We're looking at some type of a GBR procedure. We're looking at losing the front anterior incisors. These are literally floating in soft tissue. And you're going to see just how easy this procedure can be. Okay, so we have audio on that? Yeah. So with that, you can see our CT scan. Literally look at the teeth just kind of floating in tissue. Very thin, bony ridge. We're looking at placing implants in the 23 and 26 positions using a 4-unit bridge. That's typically what I like to do in the anterior mandible. But we have no bone here to do it. So looking at this, we're going to extract our teeth. This is probably the easy extraction. These are actually my assistants taking these teeth out. No, I'm kidding. So we're going to take these out and clean up any type of residual granulomatous tissue. And literally calculus is holding these in place. Okay. We're going to take these out really well. We're going to scale and clean the area extensively. And now we need to build up bone. And so, with atraumatic extraction, this is really probably the easiest extraction you'll ever see in your life. So take these out. We're going to do some type of a full thickness reflection here. What I like to do after we talked about GBR procedures and things, and this is kind of an off topic, but I don't utilize any type of burrs. I don't use any type of like small round burrs. I like to use laser. So this is a hard tissue, soft tissue laser, BioLace, water lace, and where we can do corticotomies within the bone using these small perforations with a laser. And so I typically have coined this the laser accelerated corticotomies or something along those lines. Nice tissue release. This is our periosteal release here, incisions. And so we want to get nice primary closure over any type of GBR procedure that we can. Now, Matt and John actually talked a lot about utilizing this membrane because you can leave it exposed. I try not to do that the best I can. We try to use sticky bone too as much as we want, and the handling characteristics are great. John talked about placing the bone graft in first and then draping the membrane over the top of this. And so utilizing sticky bone, the handling characteristics are fantastic. As you can see, we got things all kind of molded out here. And now watch the adaptability of the BioXclude membrane. No need to trim. We're going to use 2 of these, okay? I like to wet these ahead of time, a little bit differently than Dr. Fien did. But this will then, butt right up against our margin of our bone. Nice adaptability tucked into the lingual side, and then we'll be able to get closure over this, okay? So these are 2 20 by 30 membranes. Nice space maintenance utilizing sticky bone, but then a barrier and growth factor is now induced to our surgical site with the BioXclude membrane, okay? We'll then be able to get primary closure and success. So very easy to adapt, very easy maintaining the handling characteristics here. I like to use 5-0 polypropylene sutures, non-resorbable sutures for my crestal incisions, and then some type of resorbable suturing, simple interrupted with glycolon, 6-0 glycolon on some type of vertical incision. So GBR procedure, and this is our results after 4 to 6 months. We go back in and place our implants, and success. Okay, how about ailing implants? We deal with these quite a bit. In fact, I probably get more referrals for ailing implants than I have now than I have, in the last 15 years. And so a lot of implants out there. We see a lot of defects like this, these circumferential defects around implants. What do you do, right? Do we take the implant out? Do we try some type of a GTR procedure? Do we throw the kitchen sink at this? And I think that we can be very successful in terms of like some type of chemical debridement, laser debridement, mechanical debridement, and then throwing growth factors into these sites, utilizing sticky bone or whatnot. This is actually a video. I was at the Vatican. This is in 2018. And this is the Bramante staircase in the Vatican Museum. And so you are not allowed to pull out your iPhone and start taking video. It was like one of those opportunities where I go, man, I have to do this. Because the minute I saw this and people were going down the staircase, I immediately thought, holy crap, this is like a circumferential defect around an implant. Literally, it's like little bacteria working around the threads here. Not to say that all the Italians are bacteria. Yeah, I apologize for that. But that's exactly what I thought. And when I turned to my wife and I go, oh my God, this is a circumferential defect around an implant. She goes, you are such a nerd. Like, what is wrong with you? So, but that's exactly what these are. So we look at our case and we draw up blood. We're then going to, generate PRF liquid and make sticky bone. Kind of throw the kitchen sink at this. We debride our area really well. We place our bone, but then to adapt a membrane over these sites is super difficult, right? So, by utilizing BioXclude, we can now butt this up all the way around our implant. We can put one on the facial. We can put one on the lingual. We can get nice primary closure. Again, with 5-0 polypropylene suture. And this is our healing after 1 year. And this is what our bone looks like. And so literally going from 8, 9, 10 millimeter pockets to 2s and 3s, right? That's where we want to be. And so regeneration of bone, utilizing BioXclude, because of how easy it is to adapt. How about a perforated lateral window? I mean, as much as I like to be perfect, I do perforate, sinus membranes. And so this is a case, this is Dean. Dean is a great patient of ours, came in for an all-on-X. So we're looking at placing 4 implants, doing sinus grafting at the same time, so we can get more implants in the future to get that AP spread a little bit better. So we don't do that a lot because of the angulation of implants that we can put in, but I like that protocol where we can go through, give the patient some type of a temporary, but then also generate bone over time while they're in a temporary and then add more implants down in the future. So we're looking at implants in the 3 and 14 position in the first molars. You can see very pneumatized sinuses, okay? And so we do our surgery, we do our all-on-X. He's got implants in like the first premolar to first premolar. We give him some type of provisional. We also then access our sinus laterally and we get a perforation. And so what do you do here, right? So what are our options? One, we can abort the procedure, just not do it, right? That's fine. We can try to suture the sinus Schneiderian membrane. How successful is that? Guys? Have you guys ever sutured a Schneiderian membrane?
Not me.
Ever? On a smoker maybe that's like smoked for 80 years? Maybe, right? Yeah, I've never tried it, I never will. I just don't think it'll work. I've seen research that does show that you can do it. But why not take a BioXclude membrane? Now the adhesion capabilities of this, you put it in dry, and it's like glue that sticks to the Schneiderian membrane. Now we can then proceed with our procedure, elevate our sinus out of the way, place our graft, okay? And then we come back in 6 months, and we place our new implants. We then pick up a new provisional, let that heal, and we'll go through and give him finals. So this is where Dean started. What's great about these is that I have such an emotional bond. I do a lot of all-on-X, full arch. And the emotional, basically bond that you have with these patients where you literally transform their lives with a smile is absolutely amazing. And so this is Dean. He's a trucker, and probably the best looking smile a trucker can ever have. So, but an amazing, amazing guy. Now we're looking at doing his lower arch as well, but beautiful, beautiful case. But the healing period would have been prolonged here, and so now we can kind of push things along, repair our Schneiderian membrane with a BioXclude. How about localized sinus grafting? Sinus push, localized sinus lift. This is utilizing, specific condensing burrs or even osteotomies or osteotomes. And, you can get perforations with this as well. And so here we have a nice, probably 2 millimeter perforation into the sinus. Rather than leave the procedure and come back later, we're going to utilize either an 8x8 BioXclude membrane or in this case a 12x12. And then we can place this directly into our site, just like this, and then proceed, because of the adhesion capabilities of this, sticks to that membrane, and then we can proceed ahead and go ahead and lift up our sinus. And this is what it looks like on the day of surgery, okay? Nice, beautiful bone. 50/50 cortical cancellous chips. Don't use a lot of bio-os or those type of grafts in my practice anymore. And we can proceed ahead and then have the patient heal for 4 months and then restore the case. How about GTR? This is one of those things that I probably have the most frustrated in my practice over the last 15 years, is what works and what doesn't work, right? You guys feel the same way? I don't know. You guys, in terms of frustration with procedures and what's really changed out there, or maybe changed in your practice, what have you seen consistent? Let's say, John, you're the old guy in the group, so it doesn't look like it. It's got those genes. But in terms of GTR, how many protocols have you changed probably in the last 20 years?
Probably a few too many.
A few too many?
Yep.
You come to a meeting like this and you're like, oh, like Michael Sonic's doing like this case this way, and I'm gonna try to take it back to my practice. Or I see something on like Instagram or YouTube or whatever, and I go, oh, if it works for that guy, it's gonna work for me. This has been probably the number one, probably consistent results in terms of positivity that I've gotten out of using for GTR, right, is using BioXclude for a number of reasons. And so you can see our defect here. I always worry about vertical fractures and things like that. In this case, we did not. We accessed the area, but this is a defect that's like 11, 12 millimeter pocket, as you can see here. And so with that, we're going to try to regenerate what's missing. And so these infrabony defects, there's a lot of favoritism in terms of what's with this case, in terms of a 3-wall defect that's really making this successful. But nonetheless, adding bone here, and then we can use now BioXclude, where you don't have to trim this with those kind of cardboardy, cross-link membranes that we used to have in the past. We tried to put these interproximally, and it was just difficult to do, okay? So now in this case, we can go through, you can see our defect pretty well here, kind of goes all the way through and through. And we place our bone, and then we can also place our BioXclude. So this is like a 15 by 20 membrane that literally folds on itself. We can put it interproximally, and it sticks now to the lingual and the facial of this defect, and now we can get nice closure over this. But the other thing, too, is that when you clean out that kind of cold space or that interproximal space, there's a little bit of a void there, right? So this membrane now you can leave a little exposed, and you get nice granulation all the way through. And so a lot of benefits here. Not only can we get a nice adaptability of our membrane around our bone graft, but a little bit interproximally. If this is exposed, not a big deal, right? It's nice. You can leave it exposed. So nice closure, as you can see. And then we're going to come back through. This is where we started, okay? And this is where we are at 3 months. Nice bone fill. Call it bone fill. And then at 1 year, true regeneration, okay? True regeneration. This is consistent in my practice. Furcation defects, interproximal defects, 1, 2, 3-wall defects. And so something that, like, utilizing, I guess, with the new technology and the new parameters of using BioXclude, it's just been very, very successful in my practice, okay? How about a case like this? You don't see this very often. Brad, you love this case. Brad actually did this. He took this tooth out, shoved a bunch of bone in here, and then smashed the inferior alveolar nerve.
Remind me not to come next time you
Yeah, exactly. No, this is not Brad's case. This is actually a referral of mine that's in Las Vegas. Did the case, took the tooth out, they bone grafted, and then came back and they said, hey, the patient has numbness now, paresthesia. It's been there for about a month. It's like 2 to 4 weeks from when I saw the patient back. And obviously, with our CT scan, you can see where there was, a perforation of the defected area within the socket into the inferior alveolar canal, okay? So the damage was there. And so when we took out all of the graft, the graft was basically scooped out, and then we can then identify the nerve, okay, which is what we did here. And so as you can see this, the inferior alveolar nerve sheath is damaged here, okay? Now it's not cut, it's damaged too bad, but then what we can do is utilizing like sinus lift curettes, small instruments, being very, very careful to where now we can elevate this nerve from his bony housing and then place BioXclude now and use it like a little cast, okay? Like a little blanket, a blanket of growth factors, a blanket of protection. And so then you can place like a collagen plug if there's any type of hemostatic issues. I like to use, maybe, collagen plug or some type of a medicament you can put over this, or you can leave this exposed and just let this all granulate in, okay? And so this is what it looks like as the membrane is kind of wrapped over the top of the nerve, okay? And then this is what it looks like at 18 months. And so nerve, the canal is all, intact. And the patient, over time, over 6 to 9 months, the feeling came back, and she is completely free and clear of any type of paresthesia. So these have been documented. Dan Holzglaw from here in Texas, super, super good guy. These are some of the earlier cases that he's done, but super successful. Now, this is a 1 out of 1 case for me, right? You don't see these very often, but it worked, right? It's fantastic, okay? So inducing growth factors for nerve repair now. It's not just for, a barrier membrane. So these are kind of off-label ways that we can do this. How about, free gingival graft? I do a ton of free gingival grafts. Vinay, you're in here, brought free gingival grafts back to practice for me. A number of years ago, 4 or 5 years ago, I was a big alloderm guy or a big allograft guy. Started going autogenous again for cases like this for a number of reasons, and I've been super successful with that. But through social media and things, it's been kind of popular again to do free gingival grafts. But we do a lot of these. And so how about the donor site for free gingival grafts? And so, this is our case, mucogingival defect. We have mucositis and mucosa tissue up and around this tooth. This is a great candidate, again, for a free gingival graft. We're going to do this in the 24-25 position. We then prepare our recipient bed like any of the cases that you've ever done, okay? We're going to scale and root plane these roots, and this is where our graft's going to go. And so when we take this from the palate, as you know that there can be a lot of complications with that. And so this is our free gingival graft. I like to use a lot of periosteal securing sutures, simple interrupted, and single sling sutures to hold this graft in place. The more stability we get with these grafts, the better off we're going to be. And just some nice, pictures here of just showing the adaptation of what you can do with these grafts, and then securing periosteally here up and around the tooth and getting nice security around our graft. And so these cases are 98% successful. If I can do free gingival graft on 24-25, I would do that every day, all day. It'd be amazing. The most successful periodontist in the world, right? If you pulled implants out of my practice, man, I'm going to be super happy. But I love implants, and implants are great. So it's like this catch-22. But anyway, so this is our graft in place. Nice photos here. And this is what our donor site looks like, okay? 2 to 3 millimeters of thickness, maintaining so we don't have any greater palatine canal or issues with the vasculature here. But the palate is super vasculature. It's what it is, right? There's not one case of all on 4 where I have to come in the night of, at like 11 o'clock at night because they have bleeding or discomfort and things like that. It just doesn't happen. When I do a graft, sometimes at 24 and 25, that's when I get the phone calls like, hey, I'm bleeding again, and I have to go back into the office and help it out. And so Matt, if you ever get Matt around a bar, he will tell you a beautiful story about a free gingival graft that he did.
Yes.
The guy, the patient, called Matt and said, hey, this is bleeding extensively. And being the guy that Matt is, he actually went to the patient's house. It's great. Ended up in the patient's bedroom and was, I don't know, it's a great story. But so Matt will tell you that.
Rest in peace.
So if you get a couple of beers in Matt, he'll tell that story. I've never laughed so hard in my life. So, but what a guy. I mean, to go to the patient's house is pretty amazing. So, but these bleed. And so now what we can do is place BioXclude. This is peracryl, literally cyanoacrylate. It's just super glue. Place this in the patient's mouth, and now we got hemostasis the day, like within 5 minutes of the patient even leaving. This is all sealed off. And now we can utilize our BioXclude membrane for basically a Band-Aid, okay? Nice smiley face there. This is at 24 hours, and this is exactly what I want to see. So we got nice coagulation. Everything's all healing in here really well. Patient's super happy. You know, we're starting to get some, you know, marginal tissue healing already at 24 hours. This is at 4 days. Gone. Look at the hemostat, or look at the hemostat, or what do I think? Say it. Thank you, guys. Thank you, everybody. So, 17 days. Look at the healing here. So typically, you're looking at about, you know, anywhere from 21 to 28 days for it to look like this. But it's more the hemostasis that we can get at the day of surgery that I'm really happy about utilizing a BioXclude membrane. Okay. Then we go through, and this is our case. You know, this is at like 3 months. And so nice marginal adaptation here. This is exactly what you want your free gingival grafts to look like tumor tissue. It's great. This patient will never have an issue with recession in their entire life. You know, it's like, I love these when they come back, and this is the periodontist that treated these 40 years ago, and it looks like this still. And so, yeah, amazing, amazing result. Super successful, where we started to where we are today, okay? Hemostasis on the palate. How about congenitally missing lateral incisors? You know, these are ridge augmentations that Matt and I think Israel is going to show even more extensively, so we'll go through this fairly quick. But just adaptation of our membrane over the top of these grafts. And so, you know, you can see here we got 2 millimeters of native bone. We got nice bone height, which I greatly love. But look at this like almost bowl-like situation here where we're going to build this up, which makes these a great candidate to utilizing BioXclude. And so even with a thinner membrane, again, utilizing laser to do some corticotomies here, laser-assisted corticotomies, which you can see here. What's nice about that is you can even get corticotomies even on the facial bone of the native teeth, okay? Sticky bone, again, utilizing sticky bone, you're going to see that as a pretty consistent modality that all 5 of us use. It's so cheap and so easy to use, I don't know why you wouldn't do it. You know, draw a little bit of blood from the patient, it goes an extreme way. I mean, it's just an amazing, amazing technique, okay? Our bone graft goes in place. This is our BioXclude membrane. Again, like a 15 by 20 or a 20 by 30 membrane. We're going to adapt that now over the top of our graft. And even where it hugs the teeth here, not a big deal, right? And so graft is here, nice in place. You know, everything is all intact. There's our smiley face, making sure that we're using the right product. And we get nice periosteal release. We get good primary closure. And this is what the patient looks like when they go home. Again, now when Matt showed a couple of these cases, or John showed some of these cases that this was open, not a big deal, right? Especially in a single site, it's not easy to get this closed. So utilizing some vertical incisions and whatnot, because we did these bilaterally, it was a little easier to get closure. Did a little crown lengthening too, just so we're looking at the final product, you know, looking at the macro aesthetics here and just not just dealing with one tooth. And so come back through, and this is what our CT scan looks like over time. And you're going to see at 4 months, you know, we got nice bone here that we're going to be able to use. Look at our native bone that was here, and we're gaining 7, 8, 9 millimeters of bone. And what's great, I mean, you look at, you know, some of Dr. Fien's cases and Dr. Puterman's cases, I mean, they're growing like so much bone, it's like almost too much. Like, it's crazy. So they've perfected this technique of GBR, which I've learned a lot from. Again, now we can go through utilizing guided surgery, place our implants, go through, shape the tissue, but this is at the patient when they come back after 3 or 4 months, and then you can see now our bone here that's all here, and we're gonna be in good shape. So nice bone, everything will be straightforward. Patient needs to work on hygiene a little bit, and then once the braces come off, place our implants, guided, then we'll do some type of provisionalization, whether it be custom healing abutments or actually crowns, and start shaping tissue and getting this set up for success. How about an extraction and immediate implant, utilizing a dual zone technique? I think these guys showed this quite a bit, is where we can take a tooth out, place our implant immediately, which is favorable because now we can keep marginal tissue intact and we don't have to lay flaps, okay? And so, you know, it's like any time of, you know, immediate extraction, whether you're placing an implant right away, I like to place implants probably 90% of the time if I can. And so it's very rare that I'll graft something and then come back. And so, again, atraumatic extraction the best way we can, degranulate the area, and now place our implant. Once our implant is placed, you'll be able to see now here we have our cover screw. We're going to fill in any type of defected area here. That dual zone technique, meaning not only are we going to place bone around the bony deficiencies, but also into the soft tissue as well. And so, but now we don't want to elevate flaps because we don't want any type of shrinkage or anything that's going to cause aesthetic concerns, okay? And so our graft goes in place. Now we can then tuck in our BioXclude membrane, just like this, okay? Again, more Dan Holzclaw here in terms of references. We suture this in place, or you can even use paracryl and things like that, just even dab around the margins here and leave this exposed. Now this will turn into nice granulation keratinized tissue, okay? And so this is what it looks like after 1 week, okay? And this is very, very consistent with what Dr. Fien showed, and it's what John showed. Is this what it looks like after 1 week? This is accelerated healing in these sites, okay? Bone graft is still intact, everything is all sealed over, and now we have a nice platform for nice tissue here, what we look like after 3 months, to now we can do an uncovery and get this set up. Now aesthetically, we've got issues, right? But that doesn't matter. You know, I want to set this up for success long term. And so with that, you know, this is our before and after. The marginal tissue hadn't changed hardly any here, okay? Because we didn't elevate flaps. And so with that being said, we then do our uncovery. This is a simple, you know, just using some type of even stock abutment here. And we send this now back to the general dentist or the prosthodontist. They can then fabricate custom pieces, custom abutments, and then shade match. And so in terms of marginal tissue, you know, a little bit of a triangle here, a black triangle, and obviously we need some work here, but not bad. I did my job, right? I did everything I could to now make this successful in the hands of my referring doctor. We can also use this for non-surgical periodontal therapy, so my hygienist will use this as well, okay? So let's say patients come in for osseous surgery. You know, everybody's done it, where they come in 9, 10 millimeter pockets, you do osseous surgery, you do generation, and they come back with 4, 5, maybe 6 millimeter pockets still, residual pockets. Now through maintenance, we can then take a 8x8 BioXclude membrane and actually put it into the sulcus. And so kind of how they used Arrestin or some of these antimicrobial medicaments. And so, but with that though, you're seeing a reduction in pockets by almost 2.5 to 3 millimeters. Now these are all early studies. These are all periodontists out of Colorado. And you can see that some of their stuff is now being published quite a bit. But scaling and root planing alone versus adding BioXclude to these sites, we're seeing a tremendous amount of resolution of BOP, but also pocket depth, okay? So utilizing it in your maintenance programs can be advantageous as well, okay? All right, another case, you know, if you look at these, you know, John, I think you showed one of these where it's an extraction, facial plate dehiscence, but we still want to place an implant. So that's one of those things I'm trying to speed up the process without overwhelming the environment to not be successful. And so in a case like this, we see, you know, a facial problem here where we have a draining abscess. So we know that this tooth is either fractured or whatnot that has a problem. And as you can see, we do have a fracture in this tooth, atraumatic extraction. And so with that, I try not to elevate flaps if I can. But in this case, we have so much of a facial dehiscence here that we are going to elevate tissue out of the way. And we can afford that because of how much tissue that the patient is presented with keratinized tissue. But we also have probably a crown lengthening situation down the road anyway. And so with that, we're going to elevate tissue, but you can see our draining abscess here. See this quite often. And this is what our defect looks like. And so now, fellas, would you guys place an implant here? Would you just perform some type of a GBR, or what would you do here?
I think it depends on how contained the implant would be within the defect.
Okay.
Do you have a CBCT slice?
What's that?
Did you show a CBCT slice?
No.
Then we don't have enough.
That would take way too much time. I don't want to do that. We have too much stuff to talk about. Why would you need that?
Because I'd want to know how much palatal bone there is, how much apical bone there is.
Yeah, you can see it. We got lots.
I think we'd like to.
Yeah, I think you can. I think, well, and you look at like when we were talking last night. I know you're shooting me. You know, like 270 degrees of bony housing maybe in these areas, I think are pretty straightforward. So yeah, so what we do is we prepare our osteotomy. We can go through the parameters of how deep and how palatal, but we hug the palatal wall. This is what our defect looks like. Now that picture probably tells a little bit more of the story, right? So with this, we're gonna then regenerate this area, BioXclude over this, minimally invasive flap elevation on the palatal, and get this covered up extremely well. And so this is nice, nice cortical bone here that we're gonna build against, and it's just like this big bowl of area that we can utilize our graft. And so with that, our implant's gonna go in. This is a BioHorizons, I believe a 4.2 by 12 implant, tapered pro. And we put this deep enough because we know that we're gonna do crown lengthening down the road. We wanna make sure that this is not too, coronal, right? That is the #1 problem. I mean, if you get something coming back and you're like, man, I really wish you would have placed that a little deeper to have a little bit more emergence coming out of the socket or out of your osteotomy site. This is what you have to pay attention to your planning ahead of time because we know that we're doing crown lengthening like 5 through 12. So with that, aesthetically, we place our implant deep. And we're gonna get nice running room for our GP to go through and restore this. Bone graft goes in place, we're then in place our graft. And then our membrane, again, very, very typical of what you saw already, okay? Nice closure, again, polypropylene sutures, love these. The bacterial wicking that happens on something that's a monofilament like this is very minimal. And so patients can keep these very clean. I do not use any type of braided material in my practice anymore. I used to use Vicryl and things like that. I've never used silk. I don't know. Anybody use silk still? I doubt it. Like, that would be terrible. Yeah, I see that in my office sometimes where patients come in and they've had stuff done. I'm like, who the freak uses silk still? That's crazy. But nonetheless, these are nice. The patient can see them. They're blue. They can keep these clean really well. Cotton swab until the sutures come out after a couple weeks. But this is a beautiful suture. Again, simple interrupted. Another thing too, this is always when I teach is that this is my landmark, is right at that mucogingival junction is kind of where I draw my suturing from. It's an easy way to go. It's big, thick keratinized tissue you can suture to. You don't want to suture into mucosa and try to keep that clean for the patient. But what do we have here? Yeah, we have an exposure, so it's fine. Utilizing this membrane, things are going to turn over extremely well. And even with this exposed, you've seen it already, even with simple socket grafting or large ridge augmentations here, we can leave this exposed and it's still going to turn over and we're going to get nice keratinized tissue, in which you see here. And so beautiful closure. This is at 2 weeks when the sutures come out, okay? Then we can go through, we're going to place our implants at 6 months here. But look at the marginal tissue, everything's all intact, very, very good healing. And this is at 2 years, after the patient has had this restored, and look at the bone here, and everything's all intact. So it'd be nice to get a CT scan of that, and the more I look at that. Instagram, this is one of the things that, especially during the pandemic, to where, some of my best friends to this day are guys that I met on Instagram. For some reason, like all of these guys up here, we swiped right that day. Like, I don't know what it was, but there was something about Brad, and I mean, we host a show together called the Perio Bro Show on Instagram where we look at cases and have a lot of fun. It typically is the only time he gets me to do this is when I'm on vacation, and my wife is super upset every time we do it. But post a little bit of, family stuff, but nonetheless, in courses we do. But the interaction that I've had through Instagram, be a friend, come on, let's be homies, get on there, let's intermingle together. With that, like I said, some of the inspiration that I've had within my practice, whether it be practice management or leaning on some of these guys where I've had a bad day, I'm like, man, like this case didn't go so well. Brad and I, we get on FaceTime and we're like, man, how was your day today? I was like, man, it wasn't a good day. Like it just, it's just the camaraderie that we get, and it all started here. So, and so, like I said, it's an amazing experience that I've had through just a platform like this, and I couldn't be, more blessed to have some of the people in my life because of that. Here's some of my information. I do answer emails. If you want to, talk to me about anything, that's fine. I answer these within 24 hours. I'm not one of those guys that has, 500 unanswered emails. That will drive me crazy. Yeah, that is not me. So, but with that being said, get on Instagram, follow these guys. It's an amazing platform.